Hi, everyone, and welcome to another episode of the Cancer Now What vodcast. My name's Jenny Martin, and I'm so excited to have three very special guests in the studio here today. Amanda Sweeney, who is with the American Cancer Society, Dr. John Davis, who is a breast surgical oncologist with Comprehensive Breast Center of Arizona and Arizona Center for Cancer Care, and Dr. Arun Singavi, medical oncologist with Arizona Center for Cancer Care and the Virginia G. Piper Cancer Care Network. Welcome, you guys. I'm so glad that you're here. Thank you so much for joining us. We have Amanda Sweeney, who is with the American Cancer Society, and I wanted to get you here, Amanda, specifically with Breast Cancer Awareness Month coming up this October, and this might actually air during the month of October. So breast cancer is on everybody's minds in the month of October. So I thought it would be a really good idea to talk about some of the things that the American Cancer Society is doing to promote breast cancer awareness with this big month coming up. And then also bring in a medical oncologist and a breast surgeon to talk about what it's like for a patient when they're in the clinic. So thanks so much for being here. Can you tell us a little bit about what is going on at the American Cancer Society, some of the campaigns around breast cancer awareness?
Yeah, absolutely. Thanks so much for having me here today and giving me the chance to talk about what we're doing at the American Cancer Society. So as you mentioned, October is Breast Cancer Awareness Month, so we're all on high alert at American Cancer Society, everything breast cancer awareness, making sure that we're spreading the word. And one of the ways that we do that is through our Making Strides Against Breast Cancer event that we have every year. So that's taking place this year at Tempe Beach Park on Saturday, October 23rd.
Cool.
So that's actually one of the largest breast cancer walks in the country, and it's a really great event where we come together to celebrate breast cancer survivors and raise money to help support the mission of the American Cancer Society and all that we do to help breast cancer patients. So that includes things like breast cancer research, patient support programs, and support groups that help breast cancer patients through their journey, breast cancer screening initiatives to help patients to detect breast cancer early, things like that. So that's one of the events we have going on that helps spread awareness during the month of October. Another campaign that we have going on in October is our Real Men Wear Pink campaign.
Okay, I see a couple of real men in pink over here on this side of the table. So tell us about that.
Yeah, absolutely. And that's a really great campaign. It's a lot of fun because it really rallies the men in the community to get behind the women in their lives and really help make an impact in the fight against breast cancer. So we have a really great group of men this year that's a part of our Real Men Wear Pink campaign, including Dr. Davis, who has graciously agreed to volunteer and be one of our real men who wears pink this October. So hopefully you'll be seeing him in a lot of pink during the month of October as he helps us, spread that breast cancer awareness and also helps with the fundraising to support our mission as well.
Very cool. So tell us about the Return to Screening program, because I know that during COVID and when we were all in lockdown, a lot of people put off their mammograms. I'm rolling my eyes because I put off my mammogram for 6 months, even though I work in oncology. Yes, so these two are not happy with me, but I did get it done. So we're good. But I'm not the only one, right? Like, people put it off or aren't doing it, and that's not okay. So what is the American Cancer Society doing to help people remember that they need to go get their mammograms?
Absolutely, and you hit the nail on the head there. So many people have been putting off their cancer screenings due to COVID. COVID has affected all of us in so many different ways, and one of the ways that it is also affecting people's health is that delay in screening. So at American Cancer Society, we started a return to screening initiative, like you mentioned, and that's basically, we have a lot of different ways that we're trying to really spread the awareness and get people back into their doctors for their annual screenings. Because we've seen a huge drop in screenings during COVID. I know during last spring, during the pandemic, it was something like 87% drop in breast cancer screening. So when you think about the number of women that missed their mammograms during the pandemic, That's a huge issue. If they're not getting their screening mammograms, even if you delay it for a year and a half while you're waiting for COVID to be over, there are issues that you could be missing. If you're not getting that screening mammogram, doctors don't have the chance to diagnose that cancer early, and the cancer just keeps growing inside your body while you're putting off your mammogram.
Yeah.
So I know it's a scary thing for people to get their mammograms and to get their screenings, but we're trying to really drive that message how important it is, and if you do have cancer, how important it is to detect it early, because that's when it's going to be most easily treatable, as I'm sure you're aware.
For sure. Well, I'm so glad that the American Cancer Society is rallying around that messaging, and that we can get some of our doctors involved, right? Because it's wonderful when a support group and a support community are able to spread that message, but it's even better when the doctors get on board. So I will ask you guys a few questions about what Amanda's talking about. So Dr. Davis, as a breast surgeon, and basically what that means is that you are only dealing with breasts, right? Like, you're not doing general surgery, you're not taking out any appendix. If somebody has a breast issue, you're the guy, right?
Exactly. So I did my fellowship at the Mayo Clinic in breast surgical oncology. So I deal with anything abnormal mammograms, breast pain, breast masses, nipple discharge, anything of that sort. So any specific breast issue, I'm the person to come to for it.
Cool. So tell me, from your perspective, right? Amanda is talking a lot about the importance of mammograms. Have you seen, and I'll also ask you this question from a medical oncology perspective, have you seen an increase in advanced cancers when it comes to breast cancer because people haven't gotten their mammograms?
I actually have. I think that, during COVID, a lot of the radiology facilities closed during that time, so they couldn't really get any elective screening mammograms. But I think as things kind of gotten better, which they're getting worse again now, but you kind of see this upswing in more advanced and late stages of breast cancer coming in. So you kind of have more inflammatory breast cancers, more stage 3 and 4s, compared to finding these cancers early, such as DCIS. But I have been seeing them, and most of the time they, go directly to the medical oncologist, from that standpoint. But, from earlier stage and later stage, I think that we have been seeing more over recently.
All right, so you threw some medical terms at my lay brain, something about DCIS.
Yep.
So help me and the rest of the world that isn't a physician understand what the difference is between early diagnosis and late stage diagnosis, and why that's so important.
Sure. So DCIS is called ductal carcinoma in situ. So we classify this as stage 0. So theoretically, this can't spread to any other part of the body or metastasize. So the spread of disease to a different part other than the breast. So when DCIS usually presents as calcifications on mammograms. So if you aren't getting your mammograms, you aren't able to see the calcifications, you aren't able to get biopsies and catch the DCIS at that point. There are studies kind of showing that DCIS progress to invasive, and then, they get larger and larger. So if you don't get your mammogram, we aren't able to catch it at this, stage 0 point. And as time goes on, this progresses, turns into a mass, and then you can have, stage 1 and larger cancers that become palpable and potentially spread to the rest of the body.
Okay, that makes sense. Do you want to add anything to that
I think,
from medical oncology?
Yeah, I think a lot of people hear staging quite a bit, and they're like, okay, what's early stage, what's late stage? I'm going to talk a little bit, cancer is made up of little cells. In order to show up on imaging, you have to get to like 10 million cells. From that, those are the ones that are traveling, and to be a stage 1, it's a small cancer. It's just localized to wherever it belongs. If it starts traveling, it goes to lymph nodes. And then from lymph nodes, it can go to other places. When it starts going to other places beyond the lymph nodes is when we start saying it's later stages.
Okay.
So early stages, when we're talking about catching it, when it is among that small few million or whatever cells it is that we can see on a mammogram or an MRI.
And then from both a surgical and a chemotherapy perspective, or whatever you're doing these days with medicine infusing people, which I know is not limited to chemotherapy, you can do something about it. You're more likely to be able to do something about it when it's those smaller amounts of cells.
The smaller it is, the easier it is for us to contain.
Okay.
If you catch it super early where it's very, very small, we might not need to talk about chemotherapy. We might not need to talk about mastectomies with Dr. Davis, or going after more lymph nodes. That's the goal. Is I don't really want to talk about chemotherapy with my patients if I don't have to.
That's great.
And I kind of piggyback, on what Dr. Singavi was saying. So when I have a conversation regarding breast cancer, I kind of show them this graph, and I show them that the time, as he said, they start with little cells and they become larger and larger. So if you have a cancer that starts today with one cell, you really aren't able to see that on any imaging, whether you get a PET scan, MRI, or anything, for at least 2 to 3 years after that. So these patients that wait, for a prolonged period of time, is actually progressing this toward the later stages. So definitely screening mammograms are important just to catch the earlier breast cancers.
And what, Dr. Davis, what are the risk factors associated with breast cancer, right? So it's important, like you said, for everybody. I think, is it still women over 40 every year to get a mammogram?
Yeah, so there are different guidelines of when to get mammograms. I use the American College of Radiology guidelines. So at the age of 40, average risk women, and we can talk about risk factors, but average risk women, I usually say starting at the age of 40, and every year they should have a mammogram. And once they get to 75, 80, kind of based off comorbidity. So if they have at least a 5-year life expectancy, then I still require them, or I still discuss with them about getting screening mammograms.
Okay.
Talking about risk factors. So they are kind of hereditary, or risk factors you can't change, and then risk factors that you can change. So the risk factors that I usually go over are gender. So female gender, you're at a 12% risk of getting breast cancer. So 1 in 8 women get breast cancer. So 12%. So as a female, you can't really change that. Age, the older you get, the more likely you are to have breast cancer. Family genetics, so I do genetic testing in my office same day. With that, so if you do have, the main ones we kind of talk about are the BRCA1 and BRCA2 mutations. If you do have those mutations, kind of up to 87% lifetime risk of breast cancer. So those are some of the kind of things that modify, or risk factors that you cannot modify.
Yeah.
Modifiable ones are kind of healthy eating. We know that alcohol increases risk of breast cancer. We know that obesity increases risk of breast cancer. Most of the breast cancers these days are estrogen and progesterone sensitive, so hormones made by the body. So we know that fat turns into estrogen. So the more obese you are, the larger you are. Those kind of increase those risk factors.
So everybody always tells you, eat healthy, exercise, get good sleep, take care of yourself, and you have less of a chance of getting any kind of cancer, really.
Exactly.
Okay.
Exactly.
Good to know.
Or heart attacks too.
Or heart attacks or diabetes. Exactly. Lots of reasons why we should take good care of ourselves. Yes. So let me ask you this, and Dr. Singavi, I'll ask you this one. Dr. Davis is talking about BRCA1, BRCA2, these things, right? So I am a person in my life, as many people are, who hear these things thrown around, right? And you should get your genetic test, and you should do this, and I'm BRCA positive, so I needed to, I'm not saying I am, but if somebody is BRCA positive and they decide to have a preventative mastectomy, help us understand what these genes mean and why it's important to understand this as preventative care.
So those mutations that exist, or the gene mutations that exist, there's 2 separate types. There's hereditary ones that you were born with or run in your family. You'll hear somatic ones that are changes in the tumor itself, that the tumor acquired to make it. Those are separate things. The genetic ones are the ones you're talking about, which predisposes you to a higher risk of breast cancer, ovarian cancer, pancreatic cancer, which is where the screening stuff comes in. For BRCA mutations, something that you're born with, you have some of them are anywhere from 90 to 100% chance that they would get breast cancer. So the recommendation is, if we know that your chances of getting breast cancer are that high, once you're ready, usually before age 40 or around age 40, you want to think about a prophylactic or preventative mastectomy.
Okay.
So you no longer have breast tissue where breast cancer could develop.
And it wouldn't develop elsewhere in the body?
No, the breast cancer part it's from the breast tissue.
Okay.
So it would be from the breast. Obviously, the BRCA mutations also carry risks in other places.
Okay.
So males who have BRCA mutations are at risk for prostate cancer. Everybody who has BRCA mutations is also at risk for pancreatic cancer.
Okay.
However, we haven't quite come up with a good way to look for pancreatic cancer or screen for pancreatic cancer. We're still working on that. I'm hoping we're close to getting there.
Okay, good. So help me understand, Dr. Davis, what would prompt someone to see if they have this BRCA gene, right? Is it just family history? Or what if they're adopted and they don't know? Like, do you just tell your PCP that your primary care doctor, I want to be tested for the BRCA gene?
So there are specific guidelines. So the NCCN has guidelines of who can get genetic testing. So family history is definitely important. So if you have what we say a first degree relative, so mother, father, brother, sister, so in that first degree relative family, if they do have any cancers or anything like that, we always say that the person who is affected should have genetic testing. So any cancer these days, more than likely insurance will cover getting genetic testing. We know for sure, kind of based off certain guidelines, that any person with breast cancer, insurance does pay for genetic testing at that point. So we look at family history as kind of one thing. So certain type of cancer. So when you have a breast cancer, we kind of look at the DNA of the breast cancer or the hormone status. So estrogen receptors, progesterone receptors, and it's called HER2 protein. So kind of based off those. So the more aggressive cancers at a younger age are more likely to be from a genetic component.
Okay.
So patients who are less than 50 who have breast cancer or these triple negative or more aggressive breast cancers definitely should get tested. Anybody with breast cancer or any cancer can get tested as well.
Great. That's really helpful. Thank you. Thank you both for that. So I want to switch gears for a minute and ask, which is probably a politically incorrect question, but I know that you both get it, right? Dr. Davis, I'll start with you. You don't see a ton of male breast surgeons, right? What prompted you to want to study breast cancer and make this the specialty you went into?
Yeah.
Is that okay to ask?
No, for
Okay,
sure.
good. You never know these days.
And it's kind of like a male OB gynecologist. So
Yes.
Same thing.
Yes.
We all need good surgeons, but
Yes.
So I guess my thing was I was a second year resident. Well, when I came into residency, I thought I wanted to do trauma because everybody looks at TV and sees these trauma shows and like, oh, I want to be this trauma surgeon and it just save lives. But kind of going through so my second year in residency, I did my breast surgery rotation, and I had a pretty tough attending at that time. So we would get together every morning at 5 a.m. and go over research articles. And what we kind of started was, back when they started doing these radical mastectomies, so back in the day, they would just have a lump and they would just take the whole breast off and chest wall and muscle and everything at that time. We didn't have that much technology back then. But over time, in the research, what I found was that, going from these radical mastectomies to lumpectomy and stem lymph node, that the research that they did, back in the day actually changed the way in which, surgical management was done. And then, at that time, we were kind of looking at genomics and genetics of the, tumor markers and things like that. And they recently, I want to say 2018, they actually just kind of changed the way in which we stage. Instead of kind of how large it is, so it was this T and M&M stage. So the tumor size, if it had any metastatic potential, and then the lymph node status. So those are kind of, concrete, this is what it is. But now we know that DNA and genetics actually make up or more important. So when I talk to a patient, what I usually say is, all right, so we know what type of cancer this is. So this is invasive ductal, invasive lobular. So if we just kind of call it a dog, and what kind of dog is this? So is this a Chihuahua where it really won't spread that much, or is this kind of a pit bull where it's more aggressive and likely attack the rest of the body? So I break it down, in that standpoint, just to kind of show, how we grade things these days. But what I found was that, during my residency career that the research that we did changed the way in which we practice. And I actually like the long-term continuity of these patients. So, you get a patient, 30-something years old, come in with breast cancer. They get chemo, maybe, plus or minus. They may get radiation. We do surgery. And then I still see them every year. And then they have kids. And then they continue to come back. And you kind of have this long-term continuity with these patients, which I really like, from that standpoint. So the research changes the way we do things, and this continuity of care, kind of long-term, patient continuity is what really kind of drove me to this.
Very cool. Good answer. Very good answer.
It's the truth.
Dr. Singavi, same question to you. Now, obviously, as a medical oncologist, you don't just treat breast cancer. You treat all types of cancer. But can you tell us a little bit about why you got into medical oncology?
So I got into medical oncology in med school. Actually, my third and fourth year, I was introduced to cancer, and cancer's changing so much. And I thought it was the forefront of research. I don't think there's any other field. I'm obviously biased here, but that's changing as much as oncology is. And how many advances we've made, even the past 5 years or 10 years. We talk about overall survival for patients who are diagnosed, and that's changed by leaps and bounds because of what we can do with research. The biggest reason I'm in oncology is it lets me be part of somebody's, cancer is one of the hardest times, if not the hardest times, of somebody's life. Not just the patient, but their entire family. And very quickly you become part of that family. And I get to be on this journey and guide them through this ridiculously hard and unexpected, for the most part, journey for patients. And I love that. I love being part of that and telling you, here's what we're doing, here's why we're doing it, here's something new that's come up, here's what we can do with that. And sending people to clinical trials, things like that, to advance cancer.
Yeah.
I think, medical students ask me, or residents will ask me, would you do it again? I think it's the best job in the world. No offense.
Okay, my job seems kind of lame now, but cool. Good answer as well. Equally good answer. Well, I thank you both so much for choosing this as your career and your calling. It's very important work, and it doesn't get lost on the rest of the world that it's a lot of work and something that you really have to be called to do. So thank you for that. So I want to ask, and I want to involve Amanda in this question as well. How do you all work together when someone is diagnosed with breast cancer, right? Like, does the patient call the American Cancer Society for help? Do I know there's a radiation piece to all of this. I mean, like, how do they get through the journey? And Amanda, I'll start with you. From your perspective, how are you supporting patients when they get diagnosed with breast cancer?
Yeah, absolutely. And so in my position with the American Cancer Society, I work with a lot of different health systems, hospitals, clinics, in a lot of different ways. And one of the ways that I work with them is to make sure that they know what services and programs and resources we have at the American Cancer Society, so that they can share those with their patients when they're diagnosed with cancer. So we have a lot of different resources for patients, things that help with things like transportation and lodging, support groups, online support forums, things like that. But one of my favorite resources we have is our 24-hour Cancer Helpline, which is our 1-800 number, and we also have a live chat that you can do from our website at cancer.org. But basically what this helpline does is it is able to answer cancer-related questions that patients have and their families. It can be anyone that calls into our helpline with really any cancer-related question. So if a patient is newly diagnosed, that's a huge weight on their shoulders. A lot of times when they hear those words, you have cancer, they don't hear a lot of the rest that comes after that. And so they can feel a little bit lost. So one of the things that we encourage them to do is to call our helpline with some questions that they have. If it's questions about a specific type of cancer, if it's questions about a specific type of treatment, if it's a question on how do I navigate my health insurance plan, we can help them with that as well. So a lot of resources just to kind of be there, and even a lot of times our cancer specialists that are on the other line, they're just another ear to hear patients when they call in, someone to talk to about what they're going through.
Yeah.
So that's a really great resource for patients, and we try to make sure that the health systems that we work with are able to refer patients to the American Cancer Society for those things as well. But it's a very symbiotic relationship as well, because a lot of times if they'll come to us with some types of questions, we can refer them back. That's actually something that you really should talk to your doctor about, and we can tell them, make sure, make a list of these questions, and the next time you're seeing your doctor, make sure you're asking him each and every one of those questions so that you know what's next in your cancer journey.
And are you guys receiving those lists? Do people say the American Cancer Society said I should ask you this, 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 and this? Or I got guidance to ask you these questions?
They print them out.
Yeah, they print them out, and I think that, especially with the advent of Google, that they kind of look up everything. And the first thing that comes up is the American Cancer Society. Also kind of use a lot of the American Cancer Society things as well. And Dr. Singavi will probably see is I have my book that I kind of go through with them. And I say, when you see medical oncology, this is what you need to ask, kind of those questions. And when you see radiation oncology, this is what you should be asking. And I even have a, sheet of myself, for, when you see a breast surgeon, it's what you ask. And I usually go through all those things.
Very cool. So that just makes me think also, you triggered me to, there's a medical oncologist, there's a radiation oncologist, there's a breast surgeon. In what order and how does the patient know that these things occur?
So I think breast cancer is a multidisciplinary cancer. It's not just one. You need everybody involved. The radiation oncologist, the medical oncologist, the surgical oncologist, the patient navigators, support groups. It's a tremendous weight on somebody's mind and on their family's mind. Radiation oncology, so the way I explain it to patients is, the surgeon takes care of the local area. The radiation oncologist would take care of an area beyond that. And then as a medical oncologist, my job is to worry about everywhere else and not having this conversation about breast cancer with you 3, 4, 5, 10 years from now.
Okay.
So I think it should be everybody involved in a team that talks to each other. Dr. Davis and I and the radiation oncologist, we have a thread on our secure patient app where we can discuss, and we'll always update each other saying, hey, this person's having this. I'm going to have you, can you please look at them and get them in?
So you're texting. You're texting about patients all the time.
Yes.
All the different
in a
disciplines.
secure way.
Yes.
Of course,
In
in
a
a
HIPAA
HIPAA compliant
yes.
way. Yes, lest we forget, HIPAA compliant. However, I think that the really important piece, and Amanda, I'm sure that you would agree with this, is that you're talking, right? Like patients come and tell people at the American Cancer Society and other nonprofits locally that they don't know if their doctors are communicating. And that is huge, right? Like you don't want to show up at the medical oncologist and they don't know anything about you and they haven't talked to your breast surgeon or your radiation oncologist. So, and I think it's really important too for people to understand that community physicians who are with different groups can collaborate, right? And can have conversations and be involved in a HIPAA compliant way together to move patient care forward. And I feel like Arizona Center for Cancer Care and Comprehensive Breast Center of Arizona, they do that really well. And it's a big deal.
No, I agree. I think the one thing kind of about this group overall is that, we're, for the most part, we're kind of under one, building. So for the most of the time, Dr. Singavi is directly upstairs. We have radiation oncology. We have breast imaging, kind of all in one building. So really, I can just make a phone call and, hey, can you get this patient in a day? Give him the history. He come like yesterday, Wednesday, he came downstairs.
Yeah, you can walk down the hall.
Saw the patient, with me as well. So
that's a big deal.
I think that, that multidisciplinary team, definitely, allows the patient to feel like they're getting a good care.
Awesome.
And I don't think a patient should have to worry about trying to figure out, okay, I'm going to this person. I think you need somebody to quarterback it. Mm-hmm. Whether if they, the first person they saw is Dr. Davis, then he's the quarterback until he hands off. So if we're doing chemotherapy or systemic therapy, he hands off to me and I say, okay, I've got this right now. I'll let you know when I have updates as well. And periodically we'll still go through all of our patients and saying, hey, they're in the middle of this. This is what happened. we're doing this.
Yeah.
Or there's a complication, just wanted to update you about it.
And then do you also follow up with the primary care provider who originally did the diagnosis or made the referral to you? Is you all keep them in the loop too?
Always. So as soon as I get done with my note, I fax it directly to them. If I have their phone number, then I usually, update them as well.
Yeah, that's or her. Him or her.
Yes.
Him or...
You're wearing pink today.
I think I said them. I think I said them.
Oh, okay, you said them. All right, fair enough. Well, I am so grateful to all of you for being here with me today. Breast cancer is so important, and as Amanda mentioned, on the minds of lots and lots of people during the month of October. So I'm glad that we had an opportunity to share this conversation. It's very important stuff, a lot of information here. If anybody would like to follow up on any of the information that we shared today, you can do so with the American Cancer Society at www.cancer.org. Or if you'd like more information on Dr. Davis or Dr. Singavi, you can go to www.arizonaccc.com. Thank you so much, and we will see you next time.